I have the pleasure of introducing you to Dr. Julie Steck. She is a psychologist at the Children's Resource Group. Tonight, she's going to talk about autism spectrum disorder as a neurodevelopmental disorder that has strong overlap with mental health issues. Those with autism are at higher risk for almost every mental health disorder except substance abuse. In addition, the impact of having an individual with autism can cause increased family stress. This presentation will focus on recognizing and proactively addressing mental health factors so that the care of individuals with autism and their family is optimized. So go ahead and start, Julie.
Okay. Well, thank you all for joining tonight. I'm not quite sure how many people are on, but I hope that if you're on, you're able to multitask, since I'm sure you can't just sit around and listen to me. But we are going to cover a lot of information tonight. Let me kind of present a few objectives I have. Is that one, I want to talk about the psychiatric or mental health conditions that are comorbid or coexisting with ASD, summarize the emerging research on ASD and sexual diversity, talk about ways that you need to factor in mental health care into your treatment plan or care plan for individuals with ASD, and also therapeutic considerations when you are seeking treatment, mental health treatment. So before we get going, I want to find out a little bit about who's in the audience tonight. So Melissa, if you'll launch the first poll. Please identify what your interest or role in this topic is. Are you an individual with ASD, a parent, a mental health provider, educator, a other type of health provider like OT, speech language pathologist? Okay, we'll close that poll here in about, okay. So it looks like the majority of you are parents, a few mental health providers, and health providers and others. So let's go ahead and launch that second poll. Melissa, if you don't mind. Oh, I'll share the results. There we go. Okay. And Melissa, if you can launch the second question, I just want to find out the age group you're interested in.
Just a second, sorry. It's not letting me for some reason.
Okay, let me see if I can. Oh, here, some reason it's letting me do it. Okay.
All right, great. Teamwork.
So if you can indicate the age group you're interested in, I'm going to try to tailor what I talk about to who's in the audience and the age groups they're interested in. Okay, we'll leave the poll open just a few more minutes. I mean, a few more seconds. Okay, it looks like we really have people across the age span. The age group that's least representative is school age, and that probably makes sense. Probably between 5 and 10 years of age, people feel like they kind of know what's going on with their child. They have a school plan in place. So I'm going to stop the poll, share those results so you can see. We have really both ends of the spectrum, infants and toddlers, all the way up to adults age 25 and older. So one of the things we know through both research and experience is that if an individual has a neurodevelopmental disorder, of which autism spectrum disorder is one, they are higher risk of any other neurodevelopmental disorder and for comorbid or coexisting mental health conditions. before you all joined the webinar tonight, we were talking, Melissa and Amy and Kathy and I, about how we feel like this message is probably getting out there. If an individual has autism or deafness or blindness or a learning disorder, they're at higher risk for other neurodevelopmental disorders and comorbid mental health conditions. And today we're going to focus on the comorbid or coexisting mental health conditions that often go along with ASD. So in the 1980s and 90s, and I know it's hard to believe, but those were back in the early days of my career, the focus was on diagnosing autism spectrum disorder. We talked about, did the individual have autism, or did they have PDD-NOS, or did they have Asperger's, and where was their cognitive or intellectual ability? Then, beginning in the early 2000s, we began to recognize the crossroads of ASD and mental health. So in the early 2000s, we started saying, hey, there's something else going on here. There's anxiety, or there's depression, or there's ADHD, or there's a mood disorder. And then more recently, I would say over the past 5 to 8 years, we've been realizing this is more like a roundabout. We have the autism spectrum disorder, we have mental health conditions, we have sexual and gender diversity, and we have internet fascination and addiction. So the whole area of interacting with individuals with ASD and their families and helping design an appropriate intervention plan became much more complex. Today, the overarching goal of what I want to present is that we need to assist those with ASD in navigating those crossroads safely. It doesn't mean they shouldn't enter into those crossroads. In other words, if they have a mental health condition, let's try to figure it out and try to help them navigate that. If they're identifying with sexual diversity, let's help them navigate that. If they have internet fascination or obsession with pornography, let's help them find healthy, productive ways of dealing with those and help them establish satisfying relationships and lives. So we were talking earlier about stigma. This is not about stigmatizing. It's really about how do we assist the individuals with ASD in navigating all of these crossroads so that they can have the best life possible for them. ASD is usually the tip of the iceberg. So if you look at this iceberg, if an individual has been identified with autism or autism spectrum disorders, think of that as the tip of the iceberg. But often there are many other layers underneath the surface that we need to sort out. I did note that there are a number of people in this webinar who are either here out of interest in adults with ASD, or they are adults with ASD. Probably a lot of those individuals had many other diagnoses before they got a diagnosis of autism spectrum disorder. So in that case, the tip of the iceberg might have been something else like depression. So for example, many females with autism spectrum disorder who haven't had a diagnosis early are first diagnosed with depression. So that might have been diagnosed, but what was going on underneath, meaning the autism or the other conditions, were not diagnosed. I want to review this study that was done in 2015. I'm just going to go over it very quickly. This was done at Kaiser Permanente in California, and they did a record review, and they were able to identify well over 1,000 individuals who had diagnoses of autism spectrum disorder that were in their charts. And they then found a large number of controls. So they were able to look at individuals who'd been diagnosed with autism spectrum disorder and those that had not been. And what they found, I'm not going to go over every detail, was there were significantly higher rates of every psychiatric condition except substance abuse. Sorry, Mike. So males had with ASD had higher rates of psychiatric diagnoses than their non-ASD controls. Females had higher rates. And so we're going to go over some other studies, but that trend continues. So this study was a very large study, chart review in 2015, but there are many newer studies that are really telling us the same thing. I think what we find again and again, it's the females with autism spectrum disorder, especially those who do not fall within the range of intellectual disability, who have the highest rates of mental health conditions. So what they summarized from the study was adults with autism had significantly increased rates of all major psychiatric disorders, including depression, anxiety, bipolar disorder, obsessive compulsive disorder, schizophrenia, and suicide attempts. Pretty concerning results. This is a study that was done in 2018 looking at transition age youth. So this would be individuals with autism spectrum disorder in late adolescence, early young adulthood. The blue lines on each of the graphs represent the controls, or individuals who do not have autism spectrum disorder. The orange is ADHD, and the gray would be individuals with autism spectrum disorder. So you can see that comorbid psychiatric conditions, the highest rate was in the group with ASD. As well, anxiety was higher in individuals with ASD. Depression was actually somewhat higher in this study in individuals with ADHD. But you can see both ADHD and ASD significantly higher than the control group, or those without ASD and ADHD. Bipolar disorder, the rates of bipolar disorder look to be about 2 to 3 times higher in individuals with ASD than those without. Psychoses higher. And here we have drug abuse and dependence. That's the only group they have the lowest rates of individuals with ASD. So if you're, and I think we do have a couple of mental health professionals on here, but I think another takeaway message is individuals with ADHD alone without ASD are at significantly higher rates, risk for other mental health disorders. More recently, there have been a number of what they call population studies. And in population studies, they look at a group of people. So example, this study was done in Minnesota, in one county in Minnesota, and they looked at over 1,000 individuals with ASD, comparing them to 2,000 individuals of the same age and sex, to look at the comorbid or coexisting mental health conditions. And this was by age 30. So they found, again, a much higher rate of bipolar disorder in individuals with ASD, higher rates of depression, almost twice the rate of depression in individuals with ASD as compared to those without ASD, and significantly higher rates of anxiety. About 50% of the individuals with ASD had been diagnosed with anxiety. And we'll talk about this a little more in a minute. My impression is that 50% is a very low rate. I think it's probably higher than that, but they just don't get diagnosed with it. So the conclusion from that study, and I think this is an important takeaway message, is that an ASD diagnosis can cast a large shadow that obscures the comorbid presence of treatable psychiatric illnesses. Indeed, the diagnostic tally might well exceed 2 additional conditions. While this study focused on mood and anxiety disorders, risk in people with ASD is also elevated for attention deficit hyperactivity disorder, suicide, and psychotic disorders. There is growing appreciation for this psychiatric complexity that underscores the importance of ongoing surveillance and appropriate mental health supports for individuals with ASD. And I think those of you who are in the audience, if you have sought mental health care for individuals with ASD, you know it's woefully lacking and hard to find. So the diagnosis of ADHD should not just be a yes/no question. It should include evaluation of coexisting conditions. I know there are a number of people on the webinar tonight who have very young children. It is hard in a very young child to clearly know what the other coexisting conditions are. But I think it's important to, and we'll talk about this more, but stay connected with specialists who can help you identify, as the young person gets older, what the other coexisting mental health conditions might be. So what else might be there? Well, I would say a very high percentage of individuals with ASD also have ADHD/executive functioning deficits. So even if they don't have technically ADHD, they probably have a lot of difficulty with executive functioning. That's the ability to think ahead, the ability to look to the past and reflect on it and change their behavior for the future, difficulty with working memory, difficulty with planning and following through with a plan. So very high percentage of a large number of individuals with ASD will have ADHD and executive functioning deficits. And I want to say I could do a whole 3-hour presentation on ADHD, but don't focus on the hyperactivity. Think about the inattention, the distractibility, the impulsive responding, and the other aspects of difficulty with executive functioning. And I would say a very high percentage of individuals with autism spectrum disorder have anxiety. Again, I think it's very rare that I've seen an individual with autism spectrum disorder who doesn't have some degree of anxiety. And that doesn't always mean you have to treat it with medication, but I think individuals need to be aware of it, that a lot of times the behavioral difficulties that are manifested by an individual with ASD are a result of their anxiety, that fight or flight response. And then I think we are increasingly recognizing that individuals with autism spectrum disorder may also have a mood regulation disorder, DMDD, or bipolar disorder. We don't very often diagnose bipolar disorder in younger children, but that can become more evident as they go through adolescence and into young adulthood. over the past, I don't know, 7 or 8 years, we've been seeing increasing information about individuals with ASD regarding sexual orientation and gender dysphoria. One of the early studies was done by George and Stokes, and I'm going to just hit on this, summarize the data. There's been more data since then, but this was probably the seminal study that was done 7 or 8 years ago. First of all, the data are complex. What this study showed us, these were based on self-reports by individuals who did an online survey questionnaire about their traits of autism and their about their own sexuality. What the study showed is that individuals with what they called in this study high functioning autism, autism spectrum disorder without intellectual disability, reported higher rates of sexual diversity than their typical developing peers. I'm using the language they use in this study. So just know that that's where I came with those terms. Individuals with high functioning autism show lower rates of heterosexual attraction and higher rates of homosexual attraction than those who are typically developing. Individuals with high functioning autism show lower rates of heterosexual contact than the TD group. And females report higher rates of gender dysphoria, plans for gender transition, and sexual nonconformity to societal norms compared to males with ASD. So once again, it was more that the females were reporting more of the sexual diversity and gender dysphoria. So how does that fit into mental health? Well, this is an example of one study that looked at the mental health symptoms reported by group. So if you start at the bottom, TD, again, that would be individuals without autism, showed the least amount of fewest number of mental health symptoms. Those with ASD showed higher rates of mental health symptoms. Those who were non-heterosexual showed higher rates. There were higher rates of gender dysphoria traits in individuals with autism. Those who were had ASD and were non-heterosexual, higher rates of mental health symptoms. Those with ASD and gender dysphoria, higher rates, and those who had ASD were non-heterosexual and had gender dysphoria traits, the highest rates of mental health symptoms. So again, this goes back to traversing the roundabout. We want people to be comfortable with who they are, but make safe decisions. And unfortunately, with the internet, we're not always seeing that in our young people. Also been increased awareness that the suicide risk in individuals with autism is higher than that seen in the general population. So this is just one study that showed, this was in Utah, in between 2013 and 2017, that the cumulative risk of suicide was significantly higher in the ASD population versus non-ASD. So 17.17% as opposed to 0.11%. Once again, females, suicide among females with ASD was 3 times higher, and individuals with ASD However, they are less likely to use firearms, which is the most common means of suicide in those without ASD. Again, I'm not going to go I want to make sure we leave a little time for questions, but this was a study done in Denmark showing that individuals with ASD had 3 times higher rates of suicide attempts and suicide than those without ASD. Okay. So this is a study that was done fairly recently in the UK, and it looked at 374 individuals diagnosed with Asperger's. That would be what we call high functioning autism, or individuals with autism who don't have an intellectual disability. 66% of those individuals reported suicidal ideation. 35% reported plans or attempts of suicide. 31% reported depression, and the rate of suicidal plans and attempts increased as the rate of depression increased. Again, not to belabor a subject, but this is an online survey that was done fairly recently, comparing adults with ASD to those without. Now, as is often the case, more women responded than males. The average age was about 40. They developed a survey to identify risk factors, and they looked at both suicide and non-suicidal self-injury. 72% of those with ASD scored above the psychiatric cutoff score for suicide risk, compared to 33% of those without ASD. So there's a significant association between ASD and suicidality, even when controlling for factors known to increase or decrease suicidal risk. So in the general population, depression, anxiety, unemployment, and lack of satisfaction with living environment increase rates of suicide. Excuse me. But in those with ASD, those weren't necessarily protective factors. Rate of non-suicidal self-injury, that's self-injury that doesn't result in suicide, was much higher in the ASD group than in the general population. And non-suicidal self-injury predicted suicidality in autistic adults after comparing for other risk factors. So people often say that non-suicidal self-injury does not necessarily predict suicidality, but it does appear to do that in the individuals with autism. Camouflaging, which is pretending when individuals with ASD try to, quote, act like they don't have ASD, that's called camouflaging. And that seems to be a significant predictor for suicidality. So the increased incidence of mental health conditions in individuals with ASD appears to be due to at least 2 factors. One, the experience of having autism spectrum disorder seems to contribute to suicidality and increased mental health difficulty. But there's a wide range of research that tells us there are common genetic pathways for ASD, ADHD, depression, bipolar disorder, and schizophrenia. So that doesn't mean that that everyone who has ASD will have those other conditions, but there seems to be some common genetic pathway that results in those conditions. So what's the optimal management plan for ASD? I think first is a good evaluation, making sure that you, if for those of you who are on who are parents or individuals, at some point your child or you have had an evaluation that resulted in a diagnosis. I think the part that's often overlooked is how important educating the parents, the caregivers, and the individual are about their diagnosis. We have to put into place interventions, which are a school program, supports at home, supports at work, leisure activities. There may be a need to consider medication, but there needs to be ongoing reevaluation of the diagnoses and interventions. And that doesn't always mean retesting. It just means standing back and saying, do we have a management plan that is helping this individual move forward in having a safe, satisfying, and productive life? And if not, what are we missing? So why do we identify coexisting conditions? Well, ASD is not a one-size-fits-all diagnosis. And so we need to differentiate our treatment or our intervention or our management, whatever we want to call it, by identifying the needs. The core symptoms of ASD are very difficult to treat, but there are often interventions that are effective in treating or addressing the coexisting conditions. And understanding the coexisting condition is critical in considering medication, therapeutic interventions, parent education, and educational planning. So we have to have the full picture. So real quickly, there are a few mental health providers on. Some things I've learned by probably doing the wrong thing a lot of times, but is that in doing therapy with individuals with ASD, you have to keep the emotional tone low. Don't expect eye contact. Ask concrete questions to gain specific information. Meaning ask a specific question if you want specific information, because we know that individuals with ASD have difficulty with theory of mind. And if you ask a vague question, they may not respond at all to what you're trying to get at. Try to identify the special areas of interest of that individual in order to establish rapport and increase the comfort and interaction. Recognize you'll need to listen carefully and clarify what you've heard, because oftentimes, I learned this many years ago, what I thought I heard was not what they intended. So I needed to clarify often. I also have learned that you won't cover as much in a session as you would with a neurotypical individual. So you're not going to be able to cover all the things you think you should in a 50-minute session. And at the end of each session, you should recap and then set specific tasks or goals for the next session. Takeaway messages. The mental health component of treatment early in a person's life should be considered. I think it's important that the individual or the family find a therapist, psychologist, or psychiatrist knowledgeable of ASD. If they don't understand ASD, they're going to miss a lot of the nuances of the individual. The mental health provider should try to understand the individual's perspective and not just help the individual with ASD take a typical neurodevelopmental perspective. As one father said to me many years ago, I need to get into my son's life because he's not getting into mine. And I thought that made a lot of sense. I, as a psychologist, had to get into my client's world. I can't expect them to get into mine. And it's really important to coordinate among the individuals who are working and the families who are working with an individual with ASD. So I really want to thank you all for your time tonight.